Test 1, 2, 3. Okay. Testing 1, 2, 3.
Hello. We'll call this meeting of the Governance Committee to order at 12 o'clock. Do we have any citizens that we need to hear from? No? Okay. Then the next is the approval of the minutes. Are there any comments or changes that need to be made?
Move approval.
Second.
We've got first and second, and please vote.
Aye.
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 Thank you. I know there's no nays in that one, so. Committee chair report. She just told me I don't have a report. Yes, ma'am. All right, government's reports, updates not requiring committee action. Colin, you're up with the risk register.
Thank you. So we'll start where we always do, which is bringing back the top 5 from the risk register from the last time we met, which was March. As a reminder from the March meeting, we had a fair number of coding and billing sort of issues cycle off. And so the issues that are traditionally present in healthcare operations kind of bubbled back up to the top. And we saw that our workplace violence was number 1 and remains number 1. We'll talk about that on the next slide. Our cybersecurity core documented procedures will actually be down at number 3, controlled substances down to number 7, active shooter down to number 8, and the other cybersecurity down to number 9 as we've done coding and billing risk assessments. That's repopulated into the current risk register, which looks a little like this. So as I said, workplace violence remains number 1. It is number 1 by quite a wide margin here at JPS right now. I've received reports to the Executive Compliance Committee on this. During our last meeting, there's a lot of good work going on around this. I know the Chief Hand spoke at Dr. Duncan's most recent town hall. I thought he did an excellent job articulating where we were, where we are, where we're going, that sort of thing. And I think Ashley has briefed on state legislative action around workplace violence. So the board has been getting this fairly regularly, which is my hope that you continue in this committee and the full board to see that when our staff comes to work, they feel safe when they do so. And I will be the organization's harshest critic on this, and it'll continue to be here until the data suggests that it shouldn't be.
That's your job.
Modifier 59, we've seen this a couple of times. This is the surgery version of a modifier 25. This has to do with appending this modifier when there's 2 separate and distinct sessions during a surgery. It can also be appended at times on claims, and this would be a pro-fee finding, so the acclaim side of the house, to bypass edits where a claim's getting stopped. And so we're seeing the need for some education there. Miriam, the Executive Director of Compliance, has issued a corrective action plan to the Director of Coding at a claim around this. So there's a lot of work kind of below the surface on Modifier 59. It was a tick higher than we would like to see, and by a tick, I mean 5%. So really that's the sort of change we're looking to affect, although we do use this quite frequently. So it's an organization-wide inside of a claim education effort, which is underway. Cybersecurity continues to be one of the top concerns for the organization. As a reminder for this board, we broke cybersecurity into things we can deal with during the course of the fiscal year. So we are working through our core documented procedures and anticipate by the end of FY23 that this particular risk will have been fully mitigated. The last time I checked, it was at 85%. And so I'm feeling confident that we're going to continue to move the cybersecurity posture of the organization forward. As a reminder, from a NIST, that's the cybersecurity framework perspective, independent audits validated that we perform above the level of our peers from a cybersecurity readiness perspective. So the resources that we've dedicated to this over a period of years pay dividends when we have it independently audited. Doesn't mean there's not a risk there. It just means that we've dedicated resources and done so effectively.
Hey, Colin?
Yes.
With all the risks of cybersecurity, why are you focusing on core procedures?
Core procedures was one of the areas, like we have to set the P&P before we can go do more advanced things. I think we didn't have a good cyber procedural framework in place, and now we will after this fiscal year. So this was there were 100 things on the list. It just happened to be one of those things we thought we could affect change on relatively quickly.
But when you're saying cybersecurity is our number 3 risk, are you saying specifically the absence of, or the failure to have procedures, that by itself is number 3?
Yeah, in this particular instance, when we broke it out, we then rescored all of these items, and at the time when we rescored it, this was at or near the top of the cybersecurity initiatives that we wanted to work on. But Will can maybe better explain that.
Agreed. You know, the probability is what we're focused on. We're always trying to drive that down. The possibility is always there. By putting in the standards, more importantly, following the national standards of NIST, et cetera, and making sure that we use those as the guidelines to be able to say, have we accomplished this? And it becomes more of a checklist to ensure that we are safe and secure as opposed to identifying the holes, so to speak.
Okay, thank you.
Good. Thank you, Will. That's why I invite him.
Go ahead.
Improper use of modifier 62. So modifier 62 is when 2 surgeons work together as the primary surgeon during a case. This is a risk which is not by volume used very often. It actually was just 2 surgeons where we identified an issue. And so we are working that out. The potential claim annual impact was 193, and they were kind of lower dollar claims. So we've given a claim the option to either queue them up because it's not a great volume of claims and just look at them as they come in, or provide education, or do both. And so we anticipate that this one will drop off prior to the next meeting. The same could be said for the number 5 here, which is the coding and billing associated with bioengineered skin substitutes. There's about 5 different types of frauds around skin substitutes right now. This one in particular that we scored has to do with documentation. We looked at a small sample of claims. It did have a 32% error rate. We don't do this a ton by volume. However, the reimbursement for these is fairly high, over $1,000. And so when you start calculating what a repayment would look like with triple damages, plus a $15,000 per claim fine in the event of a false claim, it starts to get into the millions rather quickly. And so for that reason, we've given a claim 6 months to go educate the providers around this, and it's basically a documentation improvement effort. So we're not saying that the claims would necessarily be rejected. In fact, they were paid, but our documentation needs to be more clear when we're going to use these in certain circumstances.
So when are they due back with us?
September.
Resolution?
September is their deadline, and then we will re-audit it and make sure that their education resolved the issue. And then but it'll be on there until it gets resolved.
Okay.
Would it help if we also ask the claim scrubber people to put a warning there so that we can prevent the claim from coming out? Because anything we fix internally before it hit the pay system is not considered inappropriate.
Yes. When I asked them to put an edit in place like that, right now we have so many edits in place that they're trying to take some away. So I'm trying to be careful when I ask them to put a new one in place. But in this particular instance, it hit the scrubber and went and got paid. But we can put something in place like that if the education doesn't work, is I think would be the next stage plan.
Before we can fix that.
Because when we put an edit in place like that, that means somebody has to touch it. And so it's time that I don't know that I would necessarily want to dedicate to this, as opposed to other sorts of coding and billing risks that exist.
So Colin, I don't use bioengineered skin substitute products, so I'm not aware of what documentation is required, but education is always important, but it would be nice to give those practitioners decision support tools. Mm-hmm. So dot phrases, anything in Epic that can help them get the correct documentation present, even just a dot phrase or a smart text or something. Helpful, and then you can educate them to use it so that the documentation that they drop in is already compliance approved, so to speak.
Okay. I can run it through with the claim coding.
Colin, so since these are surgical issues, is it the surgeons that are routinely putting in these codes post-op?
It's primarily podiatry for both.
Yeah.
So, like Dr. Miles said, it's great if we could have a concurrent process or, a real-time billing and coding assistance at the time of the surgery, it certainly would be helpful in terms of having, accuracy and check at the time of surgery, along with the educational program.
Colin, I have another question for you, and I'm a little bit out of place here because I should have asked when you have you talk about cybersecurity and all that stuff. I know we're not required to do high trust. Should we consider doing high trust so that we can?
A high trust audit? Mm-hmm. We're going to do, when I cover audits, that can be either a risk-based one, and it will be a component of two of the audits that I have planned for FY24. So hold that question, and we'll grab it in a few.
Okay.
Any other questions on risk register? All right, on to B, compliance program updates. So I wanted to bring to the committee that we have restarted our 340B committee. For those who aren't as familiar with this program, as a reminder, it is essentially a drug rebate program for our outpatients in the pharmacy. It is a $60 to $80 million annual benefit for JPS, but it's not like we get a check or anything. It's baked into the budget of how we purchase drugs. The members of this particular committee are myself and Miriam, Nicole from our chief pharmacy officer, Whitney Franklin from finance, Joy Parker, and then Loretta Lemoyne and Misty Hernandez from our pharmacy, and Unica Johnson from finance as well. So it's a heavy finance pharmacy thing. The committee charter was revised and approved. It reports to the Executive Compliance Committee now. OPACE is where we designate which sites are eligible for 340B, so we approve changes to that. That has to match the Medicare cost report that we submit on an annual basis. At the time, we were focusing on cleaning up some of the findings from an internal audit of 340B that we had done previously. The transactions for that, as a reminder, came out 100% clean. We were the first organization that Lisa, who we had do the audit, had ever audited where their transactions came out clean. So that gave me a lot of confidence. We were working through a policy and procedure, and in between the meeting and this meeting, we were actually notified by HRSA that we will be selected for audit. So we have the kickoff meeting was scheduled actually for today. They will be in likely sometime in August, and they will do the real audit of the mock audit that we did at the end of last year. So we have a bit of a leg up here in that our director of pharmacy, Nicole Shoquist, is a HRSA auditor when she's not our director of pharmacy. And so we're feeling pretty confident that we've set our policies and procedures effectively through the 340B committee. We've looked at a larger sample of transactions, the types that will be audited during this HRSA audit. So we feel very confident going in that we're going to come out without any findings. So I will bring that back once the final audit is complete. So a timely slide.
Colin, who funds the 340B money that reduces our drug spend?
HRSA. So that's the health resource. I don't remember the rest. HRSA.
Administration.
Something administration. I don't know what the S stands for. And then 340B is a reference to Section 340B of the Social Security Act.
So, Colin, we've had, the biggest challenge that we've had is being able to get the drugs that reduce costs to those patients that we're taking care of that are not in a provider-based hospital clinic. Yeah. In other words, if it's in a claim clinic and we're taking care of the homeless through the homeless clinic, we're not able to get the 340B by regulatory compliance rules.
Right.
Yeah,
So
we're trying to work through that, but we do understand.
it's just a challenge.
It does.
It is.
There are some restrictions.
That's 340B. Also now reporting to the Executive Compliance Committee and rolling up to this committee is the JPS Multidisciplinary Diversion Prevention Team. This is something that I've wanted to see spun up and expanded since I got here. I think our diversion posture can always be in a state of improvement. We have come quite a long way in just the last year with this particular committee. I'll show you the membership here in a minute. But what this does, amongst other things, it will meet when we have a diversion event. We get subject matter experts from across the organization together to talk about it, talk about how the investigation will be conducted, who will conduct it, and then mitigation thereof, and then any HR actions. So HR is part of this committee as well. But it also meets quarterly, and we discuss larger diversions, drug diversion sort of topics and issues. It is a joint commission requirement, so we have this committee set up now. We've had some good, robust meetings, I think, so far. What we'll see in this committee, I think, moving forward is a lot more around the investigation side of drug diversion. We have a software which will be coming to the board shortly called Flowlytics. This ties into a number of our different systems, so your Epic, your Pyxis, where we have our drugs, our TimeCard, our Chronos machine, and it builds a profile of high-risk diversion behaviors. And so instead of having thousands and thousands and thousands of transactions, we narrow the pool to, okay, this is the diversion risk, this is the person, this is what it was, this was the drug involved. And so we can go investigate specific things. So we'll see the amount of investigations go way up when this happens. So this is a pretty standard tool that most organizations have. We don't have anything comparable in the organization right now. So when you see that come your way, I would appreciate its consideration and passage.
Colin, can you explain diversion?
Drug diversion is when at any point end-to-end in the control of a controlled substance, Schedule II controlled substance here in the hospital, where it has the opportunity for patient or staff to divert it from its intended use, which is for the patient. And that can be any point from when we order it through its delivery, how we stock it, where we store it, when it gets transferred to the unit to get distributed, when it's distributed, and then after it's distributed. So any point in that timeline of events for that drug, we have to maintain 100% control of it at all times. And so we have certain gaps right now without software.
And you only look at certain scheduled drugs?
Only the controlled substances. This is our multidisciplinary committee. So the pharmacy is, it's led by the pharmacy. Dr. Carla Pudi has joined, and Jill is part of this, Joy Parker, myself. We have physician representation in addition to Dr. Carla Pudi, Dr. Horak from our anesthesia team. Anesthesia at times can be a diversion hotbed in the country. And then a lot of our pharmacy experts and our HR representation, as well as Chief Hagan. That's all I have for open.
All right. So we have an executive session, and so at this time, we'll go into executive session. 108. There being no further business, I'll take a motion for adjournment.
So move.
And done.